Welcome back to 12 Days in March. In this section we will cover what the USMLE wants you to know about sickle cell disease, which is plenty. I want to start this section with a quick renaming of sickle cell disease, as that name isn't sufficiently informative. I prefer to call it an autosomal recessive disorder characterized by a point mutation. So we have some genetics here. That point mutation results in an abnormal hemoglobin with an emphasis on the globin. So we have a hemoglobinopathy. That hemoglobin polymerizes when deoxygenated. So polymerization is the essential step in the molecular pathogenesis of this disorder. Hemoglobin polymerizes, creating the characteristic crescentic or sickle cell. So these polymerized cells are fragile and suffer from abnormal deformability. And finally, the fragile cells are prone to hemolysis, which we will review, and the abnormal shape and abnormal deformability results in vasoocclusion. Occlusion in the circulation is not good. That means ischemia for end organs. If you understand this slide, you are well on your way to mastery of this topic. So why does NBME love sickle cell disease? And make no mistake about it, they do love this disease, and here is why. First, we have heme and organ system manifestations. Under heme, we have a genetic mutation. We have a hemoglobinopathy, and we have cells undergoing hemolysis. Further, once the spleen is wiped out, we have several peripheral blood smear abnormalities. There are lots of derivatives in here. Insofar as organ systems, there are so many derivative concepts, I can't even sit still looking at this slide. Systemic vasoocclusive events create a ton of organ system pathology and derivatives that we'll cover in painstaking detail. You can count on at least 3 to 5 direct questions about sickle cell disease and 5 to 7 more questions with sickle cell disease listed in the distractors. If you have a top 10 list of hematologic disorders, put this one on it. So with that background, let's launch into the must-knows and the key derivatives. So let's start with a brief discussion of the genetics. We have a point mutation at position 6 of the beta globin chain, resulting in a valine substitution for glutamic acid. I would be familiar with this substitution. It is one of the rare instances where they will describe and/or ask about the specific amino acid substitution. The abnormal hemoglobin that results from the valine substitution is called Hemoglobin S. Since we have 2 beta chain alleles on chromosome 11, a single mutation will give rise to single cell trait. That is, the patient is still able to make beta change since there is one functional gene. This is sufficient to prevent against red blood cell polymerization. Just to be clear, sickling is dependent on the amount of hemoglobin S present and the amount of oxygen desaturation. So this abnormal hemoglobin called hemoglobin S can be identified on a hemoglobin electrophoresis. I include an electrophoresis here to highlight the different hemoglobins and where hemoglobin S fits in the picture. You can see hemoglobin A is the predominant hemoglobin in normal individuals. There is a small amount of fetal hemoglobin and hemoglobin A2, which expresses delta chains instead of beta. In sickle cell trait, hemoglobin A is decreased but still abundantly present. Hemoglobin S makes up around 40% of the total hemoglobin. This is the picture of sickle cell trait. Keep this in mind. The main implication for trait relates to genetic counseling of adults. That is, patients with sickle cell trait do not express phenotypic abnormalities. As the mutation is autosomal recessive, the inheritance pattern is pretty straightforward. If 2 parents have the trait, there is a 25% chance of giving birth to a child with sickle cell disease. So what happens if you are a homozygote born with point mutations in both beta genes? Now we have no beta chains at all. That means no normal hemoglobin A. So now we have a lot of hemoglobin S instead. The patient no longer just carries the trait. They have sickle cell disease and all the trappings that go along with this unstable hemoglobin. Do note, there is a slight increase in fetal hemoglobin, hemoglobin F. Hemoglobin F inhibits polymerization, and that will be an important fact when we discuss therapies later on. Before getting into the clinical manifestations, let's spend a moment reviewing the molecular pathogenesis. The hallmark is hemoglobin polymerization. So let's walk through this sequence. The primary and indispensable event in the molecular pathogenesis of sickle cell disease is polymerization. Polymerization takes place when hemoglobin S is deoxygenated. I do have a little blurb here on the hemoglobin polymerized fibers. They each consist of 7 intertwined double strands with stacking and cross-linking. That's just informational. More important is the imagery. The polymer itself is an elongated rope-like fiber which results in red cell distortion. The deformed crescent or sickle cell is both fragile and has marked decrease in deformability. The result, which are the clinical hallmarks, includes hemolysis of these fragile cells and microvascular occlusion of the misshapen, non-deformable cells. These are the hallmarks of sickle cell disease. So what do you need to know about the deformed cell? Number 1, triggers. The majority of time, there are no identifiable triggers. It just happens. Known or recognized triggers include infection, dehydration, and acidosis. 2, is this reversible? Answer is yes. It's partially reversible when oxygenation is restored up until the point of no return. There are going to be consequences with that irreversibly damaged cell. 3, so this is a nifty concept. When does it start? The real question is when we turn off hemoglobin F and turn on hemoglobin A. The answer is at 3 to 6 months. That is, the patient isn't noted at birth with polymerization or sickling issue. I'll illustrate this concept on the next slide. In the fetus, alpha-2, gamma-2 is the predominant hemoglobin. We call this hemoglobin F, which holds on tightly to oxygen, bringing oxygen from the placenta to the fetus. The beta gene is not turned on by the chromosomal controller region. 3 to 6 months postpartum, under normal circumstances, the controller region turns on beta chain synthesis. Since it is defective, hemoglobin S begins synthesis at this time. Continuing the discussion, does polymerization affect red cell function? It sure does. We are changing the rheology of an easily deformable liquid cytoplasm to that of a viscous gel. It is this viscous cytoplasm, in addition to deformed structure, that will predispose to vasoocclusion. I mentioned altered membrane permeability for completeness. There is an occasional Q-bank question about permeability, but I haven't seen the NBME express an interest. As for survival, that is a big deal. The average RBC in a patient with sickle cell disease survives only 17 days. That is 14% of the normal lifespan. That's not so good. If they aren't surviving, what's going on? The answer is both extra and intravascular hemolysis. Extravascular hemolysis is characterized by the reticuloendothelial system, namely the spleen, clearing damaged cells. Intravascular hemolysis refers to cells that simply break down due to membrane damage. Recall that image from a few slides ago of the polymerized hemoglobin and the damaged membrane. While we're in the neighborhood, do you recall the hallmarks of intravascular hemolysis? The patient is noted with a high indirect or unconjugated bilirubin, elevated LDH, and a low haptoglobin. Chronic hemolysis will also predispose to pigmented stones. Okay, now we have abnormally shaped and abnormally functioning cells. They aggregate in the microvasculature, especially in locations where the oxygen tension is low, such as the head of the femur and the renal medulla. The next portion of this presentation will focus on the organ system derivatives. All right, we'll start with the spleen. Insofar as the spleen is concerned, there are 3 key derivatives. Students all readily identify autoinfarction of the spleen with splenic fibrosis as a complication. However, before we get to autoinfarction, there is another syndrome you need to be aware of called the sequestration syndrome. It is just as it sounds. Vasoocclusion within the spleen results in pooling of red cells with rapid splenic enlargement. This is an early manifestation of sickle cell disease, and in some patients, the initial manifestation. It is not a good one to have. These kids can go on to develop hypovolemic shock, and it may be a significant cause of mortality in children. Key point here, the spleen has not yet infarcted, and there is massive sequestration. The second point related to the spleen addresses autoinfarction. Autoinfarction refers to splenic fibrosis secondary to repeated ischemic events. The NBME is aware that you know this, so they ask derivatives based on this premise. The favorite questions have to do with infection by encapsulated organism. They assume you know the bugs, namely strep pneumonia, Haemophilus influenza type B, and Neisseria meningococcus. The more subtle question has to do with why these infections occur in the functionally asplenic host. Let me emphasize, knowing that the spleen is functionally absent is insufficient. You need to know how that actually predisposes to infection. The answer is twofold. The splenic macrophages actually filter bacteria, and splenic B lymphocytes produce opsonizing antibodies. You are encouraged to stash this little gem away. You will likely see a question to the effect of, immunization with which of the following vaccines would have prevented this outcome? This is just another way of making sure you know the organisms. The immunizations will be against pneumococcus, H. flu type B, and meningococcus. Finally, they do like the peripheral smear manifestations of asplenia. The characteristic description is the presence of Howell-Jolly bodies. Howell-Jolly bodies are described as DNA remnants. These abnormal cells will normally be cleared by the spleen. Their presence signifies loss of splenic function. And that's how they play the spleen game: sequestration, infection, and smear. Let's move on to bone. This is pretty straightforward once you get it on the brain. The patient may present with dactylitis or inflamed digits. In kids, this may be the initial manifestation of the disease. They won't quiz you specifically on this point, but they might put the information in a question stem. So don't get confused if they describe a sickler with hand pain. It doesn't mean they have psoriatic arthritis, which is another common cause of dactylitis. A more common question will relate to avascular necrosis, also called osteonecrosis. Again, this is a simple concept with ischemia taking place in the femoral head, an area of low oxygen tension. So here's the catch. They don't call it AVN. They will describe it by bone collapse or flattening of the femoral head. So just to be clear, patients don't complain of AVN. Their symptoms relate to bony destruction that follows bone ischemia. That is, it's dead bone. Dead bone can collapse or degenerate, and that is the clinical manifestation. And although I'm describing changes to the femoral head, AVN can happen in other bones as well. You will need to distinguish this symptom from septic arthritis and osteomyelitis. The key point, however, the patient with AVN will be afebrile. If an elevated temperature is reported, the diagnosis is not AVN. And that brings us to our next derivative, osteomyelitis. This is another NBME favorite. We'll review this in more detail during musculoskeletal, but let me just highlight 3 key points. Number 1, in kids, osteomyelitis is usually secondary to hematogenous spread. That is a favorite question. Number 2, one of the subtle clues of chronic osteomyelitis will be the presence of new bone formation. New bone will form from denuded bone spicules. Of course, they won't say new bone formation. The clue will be the presence of sclerotic bone fragments or calcified spicules. That is, they'll use some coded language to suggest that new bone is growing in the chronically infected bone. Third, and certainly not least, will be the organism. Whereas in other instances, Staph aureus is the most common bug causing osteomyelitis, the bug of choice in a patient with sickle cell disease is Salmonella species. Your challenge will be to sort out the patient who has osteomyelitis. Once done, choosing the organism is easy. The chief differential diagnosis will be with septic arthritis. The septic joint, however, will reveal painful range of motion, and/or they'll give you synovial fluid analysis with lots of PMN. In osteomyelitis, they will talk about lack of joint pain with passive range of motion. Remember, osteomyelitis will present at the growth plate in a kid. The epiphysis and joint is spare, so the joint itself remains uninvolved. Like I said, we'll review this in more detail during musculoskeletal. I include extramedullary hematopoiesis as a musculoskeletal manifestation, as it is characterized by expansion of the bone marrow. The skull is classic, with description of crew-cut appearance or hair on end. Cheekbones may expand as well, creating the classic chipmunk facies. This will be the language of extramedullary hematopoiesis. It won't be the target of a question, rather, they use it as an indirect descriptor of erythroid hyperplasia, and that is another point. Any condition associated with erythroid hyperplasia, such as thalassemia major, will also develop extramedullary hematopoiesis, so this finding is not specific to sickle cell disease. The presentation may be winding down, but don't let your energy wind down. The renal manifestations are big. There are 3 key renal manifestations of sickle cell disease. First is papillary necrosis. Since we are still discussing microvascular occlusion, it stands to reason that this is a manifestation of renal ischemia. Don't get confused, but there are several different ways the kidney may manifest ischemic injury. It isn't a one-size-fits-all. Acute tubular necrosis, diffuse cortical necrosis, renal failure and TTP, for instance, all represent ischemic renal injury. So papillary necrosis is just another manifestation. In papillary necrosis, the distal portion of the renal pyramids literally slough off. This is a classic presentation of coagulant necrosis. As such, the clinical presentation is easy to predict. The dead tissue may bleed, causing gross hematuria, or the sloughed tissue can cause ureteral obstruction with signs and symptoms similar to renal colic from a stone. That makes sense. We'll cover this entity in more detail in the renal section, but take a moment to consider the other conditions causing papillary necrosis. These include pyelonephritis, diabetes, and analgesic use through prostaglandin-mediated pathways. As for the lousy drawing, all the questions I've seen on papillary necrosis show a cross-section through a kidney. They have arrows pointing to the renal pelvis. You can't make anything out from the images. Just pay attention to the question stem. There will be enough info to nail the answer without figuring out the lousy Q-bank or NBME images. The images are generally just trying to highlight scarring in the renal pyramids, but you won't be able to see it. So I went with the illustration instead. The 2 other renal lesions associated with sickle cell disease include glomerulopathy and isostenuria. Isostenuria refers to the inability to concentrate urine. In this condition, the vasa recta is injured. I only mention this derivative to highlight the vulnerability of the relatively ischemic renal medulla. When you lose the vasa recta, the counter-current multiplier is compromised, which generates the concentrating defect. This is an FYI, as I've never seen a question on this complication. The bigger issue is focal segmental glomerulosclerosis. It's a good descriptive name. Focal refers to involvement of part of the kidney, thus the spelling with the K. Segmental with a big old G refers to injury to part of the glomerulus. Sclerosis is just that, scarring. So FSGS is a nephrotic syndrome. I think Dr. Sitar hit it on the head in Pathoma. He described this entity as progression of minimal change disease into adulthood, minimal change with scarring. Whereas this isn't mechanistically accurate, it's a great way to remember this entity. So like minimal change, you have foot process effacement. There are no immune deposits. The only difference from minimal change is the presence of scarring seen on H&E staining. This is the pathologic descriptor for focal segmental glomerulosclerosis. The questions on FSGS do seem focused on demographics or risk groups. They will include the pathology and ask you to pick the correct patient demographic, or they'll present a demographic with nephrotic syndrome and ask you to pick the correct pathology. Therefore, be aware of the association of focal segmental glomerulosclerosis with sickle cell disease, as well as HIV and heroin use. The other 2 organ system derivatives include the lungs and central nervous system. As for the lungs, the patient may present with acute chest pain syndrome. This is a vaso-occlusive manifestation that can result in pulmonary infarction. The only problem here is the patient presents with fever and shortness of breath. It makes it hard to distinguish from pneumonia. Pulmonary hypertension may develop over time in these patients from recurrent vaso-occlusion. And finally, stroke is common. Clinically, this is a huge deal. 25% with CNS pathology by age 45. That's a very big deal, but doesn't appear as a big focus by the NBME. So here is a summary of the microvascular occlusive syndromes we just covered. Spleen, bone, and renal manifestations are the big ones. Diagnostically, patients will manifest anemia secondary to increased cell turnover, especially during crises. Be familiar with indices of hemolysis, including indirect bilirubin, elevated LDH, and decreased haptoglobin. We previously reviewed the electrophoresis, but I have a special treat for you in a couple of slides. And finally, be aware of the peripheral smear findings. Obviously, crescentic cells will be noted, but also be aware of the premature RBC forms, such as reticulocytes and nucleated red blood cells, as well as Howell-Jolly bodies. Target cells are seen as these are present in hemoglobinopathies, representing cell membrane synthesis out of proportion to cytoplasm. As for treatment, you would correct the underlying provocative factors such as infection. Oxygen supplementation is key, but I want to draw your attention to hydroxyurea, which is an anti-metabolite. They like this question. How does hydroxyurea work in patients with sickle cell disease? The answer, it increases concentration of hemoglobin F by an unknown mechanism, but the result is a decrease in polymerization. The reason they like this point is that it highlights by reducing the proportion of hemoglobin S, you will decrease the clinical frequency and severity of clinical events. Finally, but not unimportantly, recall that parvovirus does cause transient aplastic crisis in these patients due to their dependence on a very active bone marrow to keep up with erythrocyte production, and these patients, as with all patients who suffer from chronic hemolytic anemia, are at risk of developing pigment stones. These are covered in the liver section. One quick question before I let you go. Depicted is an electrophoresis. Hemoglobin types listed on the top. So if presented with a phoresis like this one, would this patient have sickle cell trait or sickle cell disease? Since hemoglobin A is present, that is normal hemoglobin, some normal chains must be produced. So this patient has sickle cell trait, plenty of hemoglobin S, but there is also the presence of hemoglobin A. Remember this slide from 100 years ago? Why does NBME love sickle cell disease? I think you can appreciate the number of derivative concepts buried into sickle cell. It is definitely worth your time investment. If you have any questions or concerns, email me at 12DaysinMarch. Thank you.